described, type 2 diabetes in particular was characteristically defined as a disorder of hyperglycemia. In fact, that is how it's defined epidemiologically and clinically, but we have come to understand that elevated blood glucose is simply one marker of this syndrome of type 2 diabetes that is characterized not just by elevated blood glucoses, but in great part has its origins in this thing we call insulin resistance. And as Bert further described, the combination of insulin resistance with an inadequate beta cell secretory response is in great part what gives rise to hyperglycemia. But in fact, those with impaired responses to insulin also have other characteristic metabolic abnormalities, both this classic dyslipidemia of type 2 diabetes and insulin resistance, and an increased propensity to what I call bad blood vessel behavior, blood vessels that misbehave, not only the presence of hypertension, but many of the pro-inflammatory and pro-thrombotic risk factors that Dr. Sobel described. So this constellation of disorders is in fact the target of our therapies. And characteristically, our approach was to take each one as a specific symptom, to manage the hyperglycemia, to control hypertension, and to target dyslipidemia. But as you can see from this figure, what is inferred is that many of them have a common tie to insulin resistance. So the question is, how can we best approach each of these components? And ultimately, are there approaches that will allow us to improve all risk factors to some degree? So we're going to focus in the next 20 minutes or so on the management of dyslipidemia, and much of this is review to each of you who practice diabetes care, that the